Welcome to The View on GU, the place to be for translating uro-oncology knowledge to action. Here are your hosts, Drs. Aly-Khan Lalani and Christopher Wallis.
It's Saturday, February 15th. We're here on the final day of ASCO GU 2025. Thanks for joining me on The View on GU. I've got my co-host, Aly-Khan Lalani, here with me, Chris Wallis. We're going to go over some kidney and a little bit of testis data today. So we saw, I would say, the final report of a number of key studies today, Aly-Khan. We want to maybe lead into this with some triplet therapy.
Yeah, I mean, this has been what we hope was the next wave in kidney cancer, was trying to take the age-old discussion between should we do doublet IO or doublet IO TKI, let's just do better and put them all together. And by no means are we done in this space in terms of readout, but we did at least hear about Cosmic 313. And just to remind our listeners and viewers, this was a randomized trial looking at nivolumab and ipilimumab as a control arm along with placebo, which was a really interesting control arm to move beyond the Sutent story. And then against nivolumab and ipilimumab and cabozantinib at 40 milligrams. This was by definition an intermediate and poor risk trial. So I think that needs some context. So out of that group, 3/4 were intermediate risk and 1/4 were poor risk. We now saw follow-up from over 45 months. And I think that was really interesting because we had 20 months initially. A couple things off the hop. I mean, this was a group that about 65% had a prior or cytoductal nephrectomy of some sort, which is one of the lowest when you go back to the initial Nivo-Ipi trials. But what we saw, some of the updated data, that response rates for the control arm of Nivo-Ipi was about 37%. That was only improved to 46% when you put the three drugs together. This resulted in a median PFS in the control arm of 11 months, which when you think back to how the intervention arm in 214 did of Nivo-Ipi, quite similar. And the triplet arm in terms of PFS got up to 16.5 months. And we'll talk about that in the context of doublet IO TKI, but certainly that difference resulted in a hazard ratio of 0.82, which, admittedly against a control arm of doublet IO, perhaps is not quite what we would want to see as we move forward, but nevertheless, it was positive from a PFS endpoint. Now, what we really learned here was overall survival. That's what I think really people want to know. And so what we saw is that ultimately, median OS was essentially 42 months in both arms. Again, intermediate and poor risk patients. So I think, at least from a clinical status, we got the final readout. I think from a PFS perspective, there may be some places around the world that will want to use this. But I think overall at a top line, it would be hard to move the field when there's not an OS difference. I think some of the questions became, what about the treatments administered? And I think we clearly saw a challenge that probably explains the clinical outcomes. You're giving three drugs together in a trial when you do randomized trials, and there's a toxicity of some sort. Sometimes you don't know what is driving it, and many components get held, or where applicable, dose reduced. And then many times you're kind of trying to cover all your bases. You might give you might give steroids for immune therapy related side effects. You might hold the TKI because you're not sure. And that's what we saw. We saw that the median exposure of cabozantinib in the triplet arm was something in the 20-ish range. That would be kind of the lowest dose we'd want to use of cabo in general. We didn't quite get the amount of cycles of Ipi that you would expect, and certainly not what we saw in the control arm. So from a clinical perspective, that's really what the takeaway was for Cosmic 313. And, we're not quite done with the 3-arm trials. There's a Merck 642-012 clinical trial to come where there's a doublet IO TKI as a backbone there, len pembro, and then building on that with co-formulations of IO with the TKI or IO TKI with belzutifan. So that's still to come, but at least this first triplet trial read out. I think it was good to do, but I think clearly without moving OS, I think it's hard to see it moving the needle.
Do you make anything of the subgroup between intermediate and poor risk disease here? Bigger magnitudes in the intermediate subset than the poor risk subset?
Yeah, and you would have thought that when you put three drugs together, you're helping to rescue those who were what we call our poorest risk groups, those who are most afflicted by their cancer in definition by IMDC criteria. And we just didn't see that. So it makes you think that the Goldilocks principle, right? Are we too hot, too cold, or just right? And maybe 3 drugs in some of the sickest patients was too much to receive in some way. Either way, amongst this trial, it just all 3 drugs. It's not that I don't think they play well together. I think when you administer all of this, it was the first triplet trial at the time. There's going to be some caution, and you can just see how much actually was administered. So I do agree that who is at sweet spot? You would think the poorest of the poor, but if they've got like IMDC 6 out of 6 risk factors, how well are they to get triplet? I think is something I would think about.
Absolutely. It totally makes sense. So then I guess in the context of what most people are going to interpret as Cosmic 313 being a negative trial in spite of the PFS median endpoint, I think when we think about clinical practice, most people are going to probably view this negatively. That brings us back to our established backbone of a doublet treatment as first line for metastatic kidney cancer. And so we, have a doublet IO backbone here left out of Cosmic 313, but a doublet IO TKI has also become, absolutely highly adopted standard of care, certainly particularly outside of Canada, become the go-to regime. And so we saw some updates in the context of this data. You want to walk us through the updates of 9ER?
Yeah, what we ended up seeing was Checkmate 9ER, as you said. And before we just get into that, we've had the Checkmate 214 of Nivo Ipi, 99.1 months of median follow-up. Pretty cool. We've had Keynote 426, 67 months of follow-up, and the Clear trial just under 50 months of follow-up. And so now we get the updated 67.6 months of follow-up for Checkmate 9ER again. Nivolumab and cabozantinib at 40 milligrams against sunitinib. Let's say, give or take 20% favorable, 20%-ish poor risk, and the rest intermediate risk. And what we ended up seeing is largely things are mostly preserved. The majority of patients get a response, so that's 56%. Think about what we just talked about from Cosmic 313, where most did not get a response. Very low primary PD rate in the 5 to 6% range. And ultimately, we saw medians, which again, it's tough to cross-trial compare, but 46.5 months in the Nivo Cabo arm versus 35.5 for sunitinib. PFS was around 16 months. And I think, there's some interesting data shown about, how do we pick, and maybe there's a subset. Cabozantinib always had the perception of being great in bone metastasis patients. And interestingly, we actually had a CKIS abstract that we had our fellow Braden Millen from NIH lead, which just showed even in Canada, bone mets is a poor prognostic factor. Should we be giving bone protective agents? It's hard to know, but some of the postulation by Bob Motzer is perhaps, given the story of cabozantinib, it's active in bone. I'm not certain we've seen data to say that's exclusive. I think it's certainly known, but you wonder about intracranial activity of cabozantinib. Would that be a useful spot? But nevertheless, it was nice to see that updated data. And we now have essentially nearly 5 years of IO-TKIs, more than 5 years of IO-IO, and we've got the first readout of triplets. And so it does set a high bar. I kind of tweeted this out at Lalani MD and just said, I think the bar is set now. Mm-hmm. How do we disrupt when we've got this kind of outcomes? And, we're starting to get 5-year survival estimates across many trials.
Absolutely. And I think, the obvious lead in from that thought is that we need to think about different mechanisms of action, right? If we have this as the bar with our current drug classes, if you want to have a big step forward, we probably need to think about some novel mechanism of action. And so not in the frontline space, but we saw some data a little later on and, second, third, and later lines of therapy on different drug categories and approaches. I'll walk us through maybe Keymaker first, and then we'll talk a little bit about phase 1 data for a moment.
Yeah, no, I mean, and that's, I think it's kind of a tease and setting up the stage for what we expect from phase 3, but phase 3s didn't just happen on their own. They build from earlier trials. And so the Keymaker U03 study design essentially took patients who had progressed on PD-1 and TKI, stratified by IMDC risk group and whether they got a CTLA-4 agent or not. Lots of different arms here, but essentially trying to look at pembrolizumab and lenvatinib in this scenario. So already you might say, well, that combination, if it's after IO, is the activity really driven by lenvatinib? So that's fair. An arm of lenvatinib and belzutifan, and then looking at an arm of pembrolizumab and belzutifan. And, essentially what I think it's fair to say that all of these were in some way active agents. I think we saw progression-free survival and point estimates, but there's some differences. I mean, the Len-Pembro group had a PFS of about 9 months. The Bell pembrolizumab group, PFS of kind of in the 5-month range, and then the Len-Belzutifan in the 12-month range, which does make you think some of these patients were IO after IO. And so really it's the other component that's driving it. And then I think the natural question becomes, okay, is this at the stage for the readout of the Merck 6482011 trial of lenvatinib and belzutifan versus cabozantinib in patients who already received prior IO and or TKI as well. So I think it was great to see activity. It might be a hint, but it does set the stage that can we refine the subsequent line as patients are hopefully optimized on first line. And again, I'm hopeful we'll have that data on an episode of View on GU this year. That might be really interesting, or early next year.
Absolutely. I think there's a lot of moving parts, and I think that's, gives us the things to look forward to. But when we circle around, we're talking about new mechanisms of action, but we're still relying on our same clinical features to really drive our decision making. We haven't gotten to the point where we can do rational or biomarker-driven treatment approaches or personalization of care, really beyond the clinical pathological features that we've been using for decades. So we had a little bit of data on biomarkers, and I would say that I don't know that this biomarker data brings us closer to treatment selection, but maybe gives us a better ability to counsel our patients, to prognosticate, and to treatment monitor. Do you want to walk through some of the data on KIT1?
Yeah, so I think, and just before we get to KIT1, what we should mention is the Cosmic 313, which we have reviewed. I mean, there was a hint that maybe through RNA sequencing data that macrophages or M2 through this bulk RNA sequencing data, perhaps those levels were predictive of OS. And what was interesting in the Cosmic trial, and this will dovetail into what we think we might know in the future, is that the addition of cabo to the nivo-ipi in that study perhaps overcomes the M2-like macrophage-mediated immune suppression. So these macrophages maybe temper your immune response. How can you deal with that? You can overcome that perhaps by having the TKI. So it doesn't necessarily explain all of Cosmic, but I think it does show that there's something that we might be able to tease out to see which patient. So on that kind of context, right? So it needs to be explored, and we've had so many studies that looked and was set that there's going to be a bunch of signatures in one trial and just didn't go elsewhere. But I think it does. I think one of the presentations that has been a little bit more, has more momentum and has been more exciting is looking at Kindi-IDRI molecule 1. So KIM1, for our listeners and viewers, very briefly, this is a transmembrane protein expressed in clear cell RCC and is detectable in plasma, and that's important, and serum. And so previously we had seen data looking at perhaps those who have had a surgery on clinical trials. Could KIM1 presence tell you sooner than scans that cancer is about to come back? There might be a benefit, or trying to understand if you're low KIM1 after surgery, are those patients really getting benefit from immunotherapy? And I know we're going to talk about that. And then really what we saw today was, really nice presentation on the Checkmate 214 trial and trying to understand KIM1 levels. And very briefly, because this was obviously a well-known combination option clinically, but they had data from baseline and essentially at week 3, which would have been the next cycle of treatment ultimately. And they found that the presence of KIM1 at baseline, they were able to show a median, which is quite high in both arms of Sutent versus nivo-ipi, that when patients got treated with an anti-cancer agent, Sutent or nivo-ipi, these numbers started to come down, meaning your KIM1 level was starting to come down, which is obviously kind of something that's nice and what we'd like to see. But I think what was really interesting was to show that ultimately, beyond the baseline characteristics of what the numbers were, that the change in KIM1 level was associated with PFS and OS in the nivo-ipi arm. And that was, although binned into certain percentage cutoffs, like was it a drop by more than 30% or more than 10%, or was it increasing? Either way, the benefit kept going there, the more you found a change in KIM-1. So again, it doesn't create the slam dunk on this, but it's the first time we've really seen something that's got consistent hints across maybe resected cancer, maybe now metastatic disease, that there's some changes in the blood. I think there's fair questions to say, okay, it might be associated with PFS and OS, but if we saw an undetectable KIM-1, does that mean a CR or PR is coming? That's what we would like to know in clinic, right? If I check a blood test, can I be very optimistic about a CT scan or long-term outcome? So there's a lot there. I think it behooves us to be ready in places like Canada and around the world outside of, ivory tower or boutique academic centers. Can we be ready to do some of this blood test? I'm certainly interested in that because I think it's looking like in an operative, I think more than maybe monitoring metastatic, although that might be interesting, in a perioperative setting, maybe there's something for KIM-1 and kidney cancer.
Yeah, I found two things as someone who is a localized disease treater more than a distant treater. First is I thought it was interesting that while both treatment paradigms, nivolumab or sunitinib, could decrease KIM-1 levels, KIM-1 decreases were only actually prognostic in the nivolumab treated subset. So in the sunitinib patients, even though on average initiating therapy decreased KIM-1 levels, on a patient-by-patient basis, that decrease didn't provide prognostic value in that TKI patient population. So I think we have to wonder or explore, and the studies will do it, whether that same prognostic value is associated with the doublet IO and the TKI gets rid of it, or are we going to see the same thing if you use a IO TKI backbone? Is KIM-1 still going to give you that value? And I think, bigger picture, I take it as a good serological marker of tumor burden, right? We saw nice associations at baseline with KIM-1 levels and IMDC risk, KIM levels and nephrectomy status. So it all suggests to me that the overall burden of cancer cells in the patient is highly correlated with KIM-1 levels, which, as we transition back to a discussion of, the role of adjuvant therapy, is maybe really helpful to think about, non-imaging based markers to give us an understanding of whether there's disease present and the extent of the disease present that can help us tailor discussions about, whether additional either adds or changes in systemic therapy approaches are going to benefit our patients.
This is a question you and I have. I mean, we work at different centers, but let's just assume, you're conducting a nephrectomy. You might have some, Assure or other Leibovitz, scores to counsel patients, and then you can tell them about adjuvant therapy. We have discussed, and a lot of the questions we're asking the same. Adjuvant therapy, by definition, is overtreating some patients until you get a bespoke or validated biomarker to dictate adjuvant therapy. We don't have that. So this might be our first chance. And imagine if you and I had that in clinic to see who we could give it to. Because one of the interesting questions that got brought up, we all think about counseling our patients, and we talk a little bit about what's the actual percentage of the denominator that comes to a medical oncologist from a urologist who actually gets adjuvant therapy. But I was struck by a question from, certain regions in the world that said, well, if and when we get adjuvant therapy, or they have it now, their jurisdictions might only allow the patient to get immunotherapy once in their RCC journey, meaning adjuvantly or metastatic. This may not be the case everywhere. I think in Canada, we're quite fortunate. We can kind of reset the clock and go back to metastatic IO therapy if you got adjuvant therapy, but not all countries can do that. And so I think the stakes are even higher to say, we need to do better to find out which patients desperately need it, because if that's their only chance at immunotherapy, and immunotherapy is mission critical in advanced disease, you similarly don't want to undertreat the patients who will benefit. So I think we're finally getting there to say, hey, there's something of promise here. I think full disclosure, as the PI of CytoShrink trial, which by definition is stage 4 kidney cancer with a primary in situ, seeing the KIM-1 data, high levels when the kidney is there. These 2/3 of our patients got SBRT along with the immune therapy. I'm really curious about the KIM-1 changes. So in terms of our correlative analysis, it gives you something to think about.
Absolutely. I think it's a real opportunity for us to better tailor our therapies to our patients as opposed to, blanket approach. Maybe provocatively, I would say we can use it as a de-escalation strategy when you have level 1 evidence, a randomized controlled trial showing OS benefits. Maybe that should be our default. And we can use things like undetectable KIM-1 to maybe argue a subset of patients who can be spared the toxicity of adjuvant therapies. And I think
Mhm.
We can think of it either in an escalation manner or a de-escalation manner, but it
100%.
certainly adds to the discussion and adds to our understanding of the patient's disease burden and their opportunities to benefit versus risk from additional therapy.
And we need to catch up in kidney cancer. I mean, we are seeing the bladder cancer world who's had by definition at least systemic chemotherapy, neoadjuvantly, maybe having IO. In addition, has been able to monitor folks. We have adjuvant immunotherapy in bladder cancer, maybe perioperative in both settings. We have trials already embedding ctDNA to help inform us. So in kidney, I mean, our neoadjuvant space needs more. And I think our biomarker space needs more. So we can learn a lot in this, urinary cancer families about what we do. And so I think there's a lot to come.
Absolutely. I think as we try and wrap some data here, there's
Mhm.
one more sort of topic we should hit. It's always nice when the rare tumor sites get a little bit of love on the podium. And so CoTRIMS was presented today at ASCO GU. So CoTRIMS being a clinical trial looking at management of stage 2A and 2B seminoma. So this could arise obviously in two different ways. When you get retroperitoneal lymph nodes, either they can be there when the patient's initially diagnosed, or you could diagnose someone with localized testis-only disease, put them on a surveillance regime and have relapse in the retroperitoneum. So there's two different ways we can arrive here. In this study, both of them were present. And I think that fits our clinical scenarios quite well. And then historically, our standards of care for these patients have centered on a radiation-based or chemotherapy-based consolidative approach. And we know that when we do that, we get really great testis cancer control. The cure rates and the long-term testis cancer survival is incredibly high. By treating these young men with either radiotherapy to the retroperitoneum or systemic chemotherapy, usually 3 or 4 cycles, depending on the regime, carries consequences. And so we see metabolic effects, we see cardiovascular effects, we see secondary malignancies. And so the rationale here of a trial like CoTRIMS is to provide local regional therapy with RPLND as an attempt to cure while reducing the long-term systemic toxicity associated with treatment of this 2A and 2B disease. And so in the context of this trial, it was an open RPLND, nerve-sparing unilateral template, which I think is important and interesting. Many places in the world, certainly where I practice with Rob Hamilton running our testis cancer program, a bilateral template will be standard for nearly all patients going to the OR. But in this case, unilateral template was employed. And where patients had relapse postoperatively, BEP was given, but no planned adjuvant chemotherapy was given. So in this prospective one-arm trial, they were able to, successfully complete these operations. I don't think that was a surprise. We've got great experience operating on similar tumor volumes and burdens in the non-SEM patient population. But importantly, we see very good functional outcomes and pretty good cancer outcomes, I would say. So antegrade ejaculation is preserved in 88%. That means that, the surgery is being performed well. There's good nerve sparing happening. We get about 12% clavien dindo 3 or greater toxicity. That's expected complications, things like paralytic ileus or some ascites. In this case, they said all were managed conservatively. And then I think what's really important is they get a really decent response. And so they're getting a long-term and I think, robust responses. And so what they have is, a treatment-free survival of 89%. That means that we're getting relapse in 11 patients. And the vast majority of these are out of field. And so we're not seeing it's local regional failure per se. It's not in the resected areas. We get some pulmonary disease, some mediastinal disease, and a little bit of out of field abdominal recurrence. To me, that as a surgeon suggests that maybe that unilateral template decision wasn't the right decision. And you could, if you'd done the bilateral template as, the Princess Margaret way would be back to, the Jewett philosophy, that we might be able to obviate some of that and make these numbers look even better than the 89% they observed. But I think it's important to understand the context of testis cancer care. And I think in Canada, we've actually done it quite well. We've centralized. We have centers of excellence that do relatively high volume RPL&D. This is not, a space that any urological oncologist should go dabbling in now because there's new clinical trial data and the guidelines have now said that RPL&D is on the table for these patients. That doesn't mean that a urologic oncologist should now just start doing it. I think this is really emphasizing that centers of excellence should care for our testis cancer patients. And with now RP-LND joining radiotherapy and chemotherapy as treatment options for these patients, it again emphasizes the really important value of that multidisciplinary care, the multi-specialty consultation. And I think particularly in these relatively uncommon scenarios, this is a relatively small subset of seminoma patients that we need that specialized center of excellence and really high level experience.
Yeah, and that's what I was going to ask is tomorrow, what are we doing stage 2A versus stage 2B? And I think to your point, if it's centralized, we have our tumor board, this data can add to how we guide, and ultimately needs folks that do this a lot. Because as you say, the historic kind of only chemo, only radiation in certain areas, when you think about long-term outcomes for these young men, I think surgery is an option. How else can you discuss this unless you have a tumor board? So yeah, that's great. I mean, it was nice, obviously, for our podcast to have a good surgical, urologic abstract. I mean, I would just say, as we wrap here, I think the one thing looking forward that might be of interest to our listeners and viewers is just to dovetail a little bit back to kidney cancer is that, we did see a phase 1 data from the ARC-20 trial, which is an open label study looking at casdatifan, which is another HIF2 alpha blocker, and looking at outcomes, tested 50 milligrams BID, 50 milligrams daily, 100 milligrams daily. Response rates, highest in the 100 milligrams daily at 33%, admittedly small numbers, shorter follow-up, but it's already leading to, and I think what people should hear shortly opening, a PEAK-1 clinical trial for patients who have had prior immunotherapy, randomizing to cabozantinib 60 plus placebo or cabozantinib 60 with 100 milligrams of casdatifan, a primary endpoint of PFS, and this is a phase 3 trial. So, you can imagine that we talk about adjuvant IO, what do we do next? And so hopefully we'll see in the context of already having some data on belzutifan where casdatifan will go. But Chris, props to you. You got that late night voice. So I'm sure it was an early tuck-in for you, and you powered through. We made it through our third day. It's always busy, a lot going on. It was a lot of fun, man. We're back.
Absolutely. And it's great to be back on the horse, eh?
Yeah, it is. And we got a lot more to come. So thank you again to our viewers and listeners. Don't forget to rate, review, subscribe, give us feedback. Tell us what you're looking forward to. We got a lot coming this year. But with that, I'll wrap. On behalf of my co-host, Chris Wallis, I'm Aly-Khan Lalani. Thanks for joining us. We'll see you next time.